Good morning. That was fantastic, Dr. David. I've always admired him. And he talked about the aorta. So aorta, in my mind, is the crux of the heart, if you ask me. Everything surrounds the aorta. So does the ASD. Remember, right? So I'm an interventionalist, but I speak on imaging more than I speak on interventions. So we're going to go through anatomy of the atrial septum, and then we'll do pre-closure imaging, okay? But I want to pay tribute to Dr. Benson here. If you see this guy, we were in Da Nang in Vietnam, and they were teaching us how to cook pancakes. This gentleman paid attention more than anybody else, watched exactly how it was done, and then he made his own pancakes. And I asked him, why are you paying so much attention? He said, because I have to eat it. So I think that's his motto, I think, throughout his life. I'm very, very impressed. I'm always honored to be around him. I think he's probably one of the best interventionalists ever in pediatric interventions. So we're going to start, and I'm going to pick on you guys because Eric told me it was completely allowable. So if this is tricuspid valve, this is coronary sinus, this is limbus of the atrial septum, what kind of ASD is this? Sweet. Okay, if this is limbus of the fossa valis, this is superior vena cava, this is atrial septal defect, and this is the right upper pulmonary vein, what kind of ASD is this? This is very easy one. Somebody says, I don't want to pick one. Thank you. Okay, so this is sinus venosus ASD with transesophageal echo. And if you see in this still pictures, in four-chamber view, you don't see an atrial septal defect, but when you go to the bicaval view, you definitely see a very large atrial septal defect, and the structure above it, always initially, if you're not paying attention, you will think it's some, what is that? That is always right pulmonary artery. Okay, so what type of ASD is this? Can you run this again for me? There was some glitch. I took this patient to the lab, and I decided not to close it. Fantastic, yes. This is IVC type sinus venosus ASD, way at the bottom. So you see that? Way at the bottom. Here. So that means if this is a superior vena cava, this is limbus of the fossa valis, here is a coronary sinus, this is, what ASD would this be? Say it. Partial AV canal ASD, right? Okay, fantastic. So you guys have definitely some idea about atrial septal defect. So one of the slides that you really want to, if you don't forget this one, I think I did 25% of my work for this lecture, will be to pay attention to this. If you look in the four-chamber view of the heart, there is part of the atrial septum here, which is called atrioventricular septum, right? So that means that separates the right atrium from the left ventricle. That's why. And the primum ASD, or atrioventricular septal ASD, is in this location. And that's why you always have cleft in the anterior mitral valve leaflet, because the ASD descends downwards, it has to break open the anterior mitral valve leaflet. And here is a primary atrial septal defect. So now quickly going to the rim nomenclature, which we classified a while ago, was based upon this structure. If this is PFO, septum primum, septum secundum, aorta is in this vicinity, decided to name atrial septal rims according to the structures they were adjacent to. A, anterior aorta, SVC, superior, posterior, IVC, atrioventricular valve rims. So AV valve rim on the left side, coronary sinus rim would be somewhere here. That's your coronary sinus. You should try to evaluate it. This is one of the very common reasons for device embolization. People don't realize it, especially when they see IVC rim, some adequacy, and then the device still embolizes to the right atrium. This is what's happening in these patients. Okay, so what's wrong with this atrial septal defect? Very quickly, I don't want to take a long time on this. What's wrong with this atrial septal defect? Should we close this case or this defect or no? I know you need more information, you can safely say that, but based upon this, what is wrong with this? So this, what is this? That's the posterior rim? Good, good. So that is definitely not the posterior rim because this patient doesn't have any posterior rim. It's way up there. It's completely missing. And this is exactly when you go to real bicable view, even IVC rim is completely missing in this particular patient. The second and the last, the aortic rim. You just had an amazing talk with Dr. David about the aortic valve and everything. Aorta is everywhere. Remember that. It's absolutely. And aorta is always sitting wedged between the mitral and the tricuspid valve. So it's very, very close to the non-coronary cusp of the atrial septum is very, very close, almost in the middle of the non-coronary cusp. And that also means the aorta carries significant circumference of the ASD. The bigger the ASD, the more it can be exposed to the aortic rim, right? So that also means that you could have no rim here, absent rim here, but you have some rim here. You may have some more rim here. You may have more rim there. So is this a contraindication to close ASD? No. But if you have an ASD that goes through these dotted lines all the way up, and you are exposed to a significant expansion of the septum, then you have a problem there. Your device is so much exposed to the aorta that as the aorta pulsates with every beat for 100,000 times a day roughly, you can cause injury absolutely to the atrial free wall, left or the right, and then ultimately to the aorta. So that was a case which he said, but I was asking, should we close this defect? And of course, if you do close this defect, device will embolize always to the right side because the IV serum was absent, and here's your device sitting in the right ventricle. Okay, so very quickly, this is Adam Kolesnik. Can you run this for me quickly? There you go. This is Adam Kolesnik's, fantastic. So this is atrial septal defect or PFO, and the area that he's going around is what you call the limbus, okay? Everything that surrounds the PFO or the atrial PFO or the atrial septal defect is the limbus or the atrial septal rims. Everything, 360 degrees, remember that. Okay, and here inside, if you look at it, if this is the fossa ovalis, this is the triangle of Koch, this is how the AV node goes towards the anteroseptal commissure of the tricuspid valve, dips down. And that's why if you have IV serum absence and you put a device big enough so that it will wedge there, you may have rhythm issues in those patients. So AV block, very, very uncommon, but will happen in on those patients. This is if it was anatomically. So quickly going again through the rims, the original rim definition is here, posterior, superior, anterior, superior. And as you can tell, to me, this was very confusing when I started doing interventional cardiology. And that's why we thought to rename these rims according to the adjacent structures. Now I'm supposed to quickly going through the TEE first. So 3 standard views, remember that. 4-chamber, bicable, and short axis. It means 6 rims, 3 standard views. If you do that in all pediatric patients, you will most likely not make a mistake. Okay, or at least 2 orthogonal views, right? So if you use a transesophageal echo, you're in the mid-esophagus, and at 0 degrees, always look at the pi, as I said the day before yesterday, pi never lies. If you're at 0 degrees in the middle of the atrium, you'll always be in the 4-chamber view. Okay, you can rotate the transducer clockwise, you can rotate the transducer counterclockwise. These are the structures you should see. And here's your reference line now. That's where the eye of the TE probe is, and this is a 4-chamber view. You see a small to medium-sized atrial septal defect, right atrium, left ventricle, left atrium, and the coronary sinus. Now, what else can you do here? You can push the TE probe down, depending on the patient's size. If it's too tall, maybe deeper. If it's short, down. And what you see, the reference line move down, then you cut across the coronary sinus. Here, you start seeing the coronary sinus. Just by pushing it down, you start seeing the coronary sinus, and you can appreciate here the coronary sinus rim. What else can you do? You can push the transducer up, again, depending on how tall the patient is. And what you're going to see is that when you go up, you see the aorta is here in the background. So you should start seeing the origin of the aorta. See that? The aorta. So what you did by just pushing and pulling is you actually evaluated the whole span of the AV valve rim, from the coronary sinus, which is the crux, back side of the heart, to the aorta where it starts becoming the aortic rim. Does that, okay? So this is why, that's why sometimes when you put a device and you say device was 3-4 millimeters away, and yet patient had mitral valve perforation. So you read the literature, there are at least 10 cases described. And if you look at it, because they did not really look at the whole span. It doesn't gonna come to bite you all the time, but once in a while it can bite you. Same thing for short axis, you're gonna change the angle from 0 degree reference to 20, 30, 40, 50, 60, 70. You go all, that is all aortic rim. So here for reference is 45 degrees. Again, the structures that you are going to see is the aortic rim, the posterior rim, the aorta, right atrium, and left atrium. So the dotted line is the reference point, the 0 degrees, and you go from 30, 30, 40, all up, towards 90, even 120. You see the aortic rim, the posterior rim, the aortic valve, 3-leaf, left, and the right atrium. Now we go from 90 to 120, even 90 to 130, 140 degrees, that will be the bicaval view, okay? In the bicaval view, you are going to see, of course, the left atrium, the right atrium is SVC, IVC, and most importantly, the IVC rim. You have to see the IVC rim or adequacy of the IVC rim that you can close the device. So again, from the reference dotted line, go to the bicaval view, you see the SVC rim, the IVC rim, left atrium, right atrium, part of the tracheus valve, and even the right atrial appendage. So 3, remember that. 4-chamber, short axis, bicaval view, and you have evaluator 6 rims. Most of the time you will not make mistake. Okay, now ICE. We talked about it. ICE or ICEs, both are bad, remember that, okay, in so many ways, in Australia especially. There's one Australian arrested every 6 minutes. So there's one guy who's from Australia, isn't it? Yeah. But he's in Canadian jail. So I think this is methamphetamine, that's, they call it ICE there. So say no to ICE, but today we'll say yes to ICE, okay? So the AccuNav catheter it has 3 knobs, and if you remember, we talked about it the day before, the evening before last one. The most proximal knob is the posterior anterior knob, then the knob next one is left, right, and the final is the lock mechanism. Okay, so what you do, most important here is you go to the home view first, and the home view is going to show you the right atrium, the tricuspid valve, the right ventricle. How you see the right upper pulmonary vein, sometimes you always wonder, it goes slightly high into the superior vena cava, SVC, RA junction, you can do that in the fluoro, rotate the eye to the right side. Okay, you can see the eye, rotate the eye to the right side, and you will see ton of flow coming towards you, and that is the right upper pulmonary vein and right lower pulmonary vein. Okay, you can see the aortic arch, you can see a lot of other things, but we'll focus only on atrial septal defect. This is the other catheter that is available, ViewFlex Extra from Abbott. Its Agilus handle is very, very easy to use. Its color flow is color images are way better than the AccuNav images. If you are used to AccuNav, you will have a little bit harder time getting used to it, but if you do it 2 or 3 times, I think you will get very, very good experience with it. So how I do it, I go to the home view, I never lock anything, keep it straight, rotate the transducer slowly clockwise till you see the mitral valve, the appendage, the pulmonary veins, the descending aorta, even the right pulmonary veins. And then come back, and when you see the aorta, there's where you lock it if you have AccuNav, and then do anterior posterior tilt to do the images. So here are the views that you can get with ICE. The home or the neutral view that I call it, the superior rim view, I'll tell you what I mean by it in a second, the bicaval or the caval view, and then the short axis aortic view. So you have to be able to get these 2 views for sure. Bicaval view or the caval view separately, and the short axis view, okay? And the AV valve rim, you can always look and evaluate when you're doing a neutral scan going clockwise, okay? So as I said day before yesterday as well, there is no real 4-chamber view. You are even on the 4 chambers. So you can have a 3-chamber view in these patients, okay? So here's the pictures. I don't know if this will run, but this is the home view. You can see a lot of things here. You can see the eustachian valve. You can see the right atrium, the left atrium, tricuspid valve, RV, RVOT, part of the aorta. ASD is supposed to be somewhere in this vicinity, okay? Here you're going to get the superior, which is a rim towards the pulmonary vein. Is the rim, if you know ICE, conceptualize like this. If you are in caval view and you start rotating the catheter before you, or rotating the catheter right-left knob, before you get to the bicaval view, to the short axis view, you will pass through an area where you will not see the SVC or the aorta. Okay? That is superior rim. And that's exactly what you see here. That is the superior rim, that's the rim towards the pulmonary vein. Okay? Short axis view, as I was saying, you can do it with the right-left knob or rotate the whole catheter medially. So you look into the barrel. Essentially, the aorta is here, and you will see a beautiful short axis view. Really, really easy to do if you conceptualize it. Quickly going through, this is a short axis view, real life. Here is IVC rim view, very, very easy. Pull the ICE catheter, pull it back, and you can see it very well. So I want to tell you what's coming in about 6 to 9 months, maybe next year. This is a new digital steering technology, which I presented last year at the CSI, and I can show it in Canada, not in the United States, actually. So this is almost TEE, but with ICE technology. This is ICE catheter, 9 French compatible. You put in the right atrium, you don't have to do anything with it. Knobs are all outside. And you can go from -60 to +60 degrees and go from cable view to short axis view without touching the catheter. It's absolutely amazing technology. These are some of the images that we got in pigs. And you can see just by changing the angles, I changed from long axis view to the short axis view. The catheter, I did not even touch the catheter. The person who was doing this thing, they were rotating. Phillips. It come probably 2020, beginning of 2020, yeah. Okay. And if we compare exactly the same images between AccuNav and also NeoIce, and you see at the right side, actually the images with this NeoIce, they call it NeoIce, is another name for it actually, are better. And plus, it has very useful 3D images, real-time explain, amazing images. So for tricuspid valve technology, you've got to have a fun doing these cases because you can see the tricuspid valve so well in them. So anyway, so now part of the procedure you do balloon sizing. So one thing, I want to show you something there. One thing when you're doing the device, even if deploying the device, even if it's a small defect or a large defect, always, always, always rotate the sheath. So it, instead of facing this way, it becomes parallel to the spine. If you do that, you will cut down your time of procedure for complicated cases by 50 or 70%, because that will bring the sheath parallel to the septum. So if you notice here, so I'm rotating the sheath so it becomes parallel to the spine. The more parallel it is, the left disc is parallel now to the septum. It is illusion that if it is this way, disc is this way, is parallel. It's not. That's when it's very close to the aorta and it pops out if you're doing a large ASD. The more parallel the sheath is to the septum and you pull it towards, you are going to be a lot more, many times more successful than to pop up the thing. That's a very simple thing, and I think you should do it. Try to do it on every case so your hands have this memory, muscle memory. Hausdorff sheath was the same idea. He was a very smart guy. If you see the angle is such in the right side that you see, it becomes parallel to the spine. You really don't need Hausdorff sheath. If you want to use it, that's up to you. But you can use a sheath, regular sheath, and rotate it. Hausdorff sheath does exactly the same job which you do, which you can do just by clockwise rotation of the sheath. All right, very quickly, what rims are these? Huh? So the pi never lies, right? It's SVC rim, and bottom will be the IVC rim. Now, Spidey, since I have time, 5 minutes? No, thank you. Thank you. So there are a lot of ASDs that absolutely tingle me sometime, and I decide not to do them. One is a spiral septum ASD. I cannot understand it. Maybe Dr. Benson will give us some pointers. Multiple angles absent atrial aortic rim ASD, which is very difficult for me to say yes to do this case, no matter what device you're using. Malaligned septum atrial septal defect, very difficult to deploy device and a high risk. And the absent coronary sinus rim ASD. When I evaluate that, I try not to do that. So here's a complex atrial septal defect. If you look, this was a 16 millimeter ASD patient, weighed about 10 kilograms, so not very small patient. We should be able to, I think 16 or 15 ASD. 4-chamber view, transesophageal echo, and you can see some blood, the flow, which looks like pulmonary venous flow, right? This is a bicaval view. You hardly see the defect, which is a torrential amount of flow to the left atrium. We tried to put ASD device. I spent maybe 45 minutes trying to put the device. It absolutely popped out, or it looked ugly so bad that I didn't want to leave it. So then I put cardioform device, the largest they made. It stayed there for about 2 minutes, still attached, but it popped out. So anyway, we were still attached to it, so we took it out. And this patient still doesn't want to have surgery. Yes, told her, I said, please go have surgery, but mother doesn't want to have surgery, so we'll figure out what we're going to do. So I said, what is really going on that I cannot do this defect? So I sent this information to Steve Pofeld. He does 3D reconstruction with CT and transesophageal echo. Can you run this for me? It may take about 30 to 45 seconds, but you see how complicated the septum is. He goes from the left atrial side, and as he goes in, you will start seeing the septum. I wish I could fast speed this. You see the septum there? 1, 2, 3 turns. 1, 2, that. So this is the recess that you see, where you see the accumulation of a lot of blood. So that's why it was confusing to me. Where should the device sit when I'm doing TEE? Where the device should sit in this. This is no rim, actually, absolutely. If it is there, it always sits cattywampus. Should I leave it? I could wedge a big device, but am I doing justice to this very young baby? Remember, I told you guys, keep in your mind, would you do that to your own son or daughter?
Can you go back to the TV and just try to show us on the TV that?
Okay. Yeah, sure. It will be. Okay. So. Yeah. So here, by transthoracic echo, we saw atrial septal defect in this area. This was very bothersome. I had no idea what I'm doing. This area was coming, and looks like this is almost intact septum. Then we see flow, which is, I would say, left upper pulmonary vein flow. Would you say that? But maybe higher velocity, but left upper pulmonary vein flow. And I could not. And then, unfortunately, I don't have all the images on this because of the time constraint. But God bless it. Sorry about that. Can you run that, if you don't mind? So, thank you. Okay, now we go forward. So SVC rim looks adequate. See this flow here? So there was another area. So there is one notch here, there is one notch here. So this is the septum, or this is the septum. And in this 4-chamber view, I don't see the defect. So defect is anterior to it. Does that make sense? And we are not in the way back portion. And you did not see the defect in by cable view. So it's definitely not posterior, inferior either. It's not in the 4-chamber view. So it is much anterior defect. And when it comes to here, so here you see these 2 septum. Okay. So I was completely confused here. What's going on? If this is the pulmonary vein, why is this red flow in the middle of these 2? But that's the spiral septum. That's where the pulmonary venous blood comes and then, kind of gets agitated and hits the roof. There is nothing in there. So I wasn't sure when I saw the ASD. I wish I could had another picture where I could show you the ASD. If I would put the device here, or would I put the device on this septum? We tried on both sides, and it absolutely didn't want to work. So going there, all right, let's run this quick. Can you make it fast forwarded? So when you go from the left atrial side here, you can start appreciating, that's your atrial septal. Okay, let it run, it's okay. Start appreciating. 1, 2, see this? This is truly spiral septum. So you don't know where the device should be. It gets cattywampus like this, it doesn't close. And here, see that? So here there is absolutely no rim. This is some rim there, this is some rim there, but they are not aligned at all. It's almost in a 3-dimensional, 2 different planes. So I had a very hard time, and by TE I was never happy. I did not know this anatomy at that time. Now if you go to the right atrial side, actually it becomes even clearer. You see, it becomes clearer here. So he said, Steve said, it almost looks like a sinus, superior sinus venosus. Wanna be sinus venosus ASD, but never became because the pulmonary veins were draining normally. So anyway, still confusing to me. So I tried this patient twice. I don't want to anymore. Okay, so there are a lot of ASD that still bothers me. This is Dr. Amplas. He, in my opinion, is also one of the genius people. He invented the ASD device actually when he was 72 years old. So in last February was his 96th birthday. I have a picture of it, but he didn't want me to show it because he has a trach. He's mentally as sharp as he was when I met him when he was 72, and even now, but he didn't want me to show the picture. So with that, and this when he was a really young child in Austria. Thank you very much.